Good evening, everybody. My topic is basically, I will keep it as the clinical one, the musculoskeletal manifestations of diabetes mellitus. So this is the overview. I'll be discussing about the common musculoskeletal manifestations, the presentations, and management outline. Although it will be very difficult to discuss the whole in over 15 minutes time, I will try to complete it. So these are the musculoskeletal manifestations of diabetes mellitus. If we see, we have a whole list of diabetes mellitus manifestations that might include some intrinsic complications, those which have increased incidence and which are having possible associations. And the prevalence are actually not less. If we compare to the non-diabetics, the musculoskeletal manifestations are in fact many are having much more prevalence as compared to the non-diabetics. So let's start with a few cases. The first case, a 32-year diabetic for 10 years on insulin presented with pain on movement of the shoulder joint since last 1 month. The patient had restricted movements of abduction with a fasting blood sugar of 122 and 2-hour postprandial of 178. So what's the most probable diagnosis? I'm sure everybody will say that it is a case of frozen shoulder. Yes, that is. And that is also known as periarthritis or obliterative bursitis, which results in progressive painful loss of motion in all directions and wherein the joint capsule adheres to humeral head. It is associated with type 1 and type 2 both. In diabetics, it occurs at a younger age, associated with a higher mortality, and treatment includes steroid injections along with proper glycemic control. If you go to the next case, very common again, a 55-year male diabetic for 22 on metformin, glimepiride, ramipril, presenting with progressive painless swelling of the left foot associated with deformity, peripheral sensory neuropathy, and joint crepitus involving the first MTP joint. I'm sure again everyone will be agreeing with me that this is a case of Charcot's joint. Charcot's is actually a leading cause of diabetes is actually a leading cause of Charcot's arthropathy, wherein there are many other causes also. So herein the destructive arthropathy occurs due to impaired sensory function, but the motor function here is normal. There are no sex in the differences, and the prevalence increases with duration and predominantly in the 50 to 60 70 years age group. Most common in the MTPs, and other joints might also be involved. Single painless swollen deformed joint in the setting of peripheral neuropathy is a classical description of Charcot's joint. Repeated microtrauma with weight-bearing damages the joint, and that causes the aggravation of the joint disorder. These are a few clinical pictures and X-ray features of Charcot's arthropathy. Diagnosis is mainly clinical, then X-ray, CT, and bone scintigraphy. Treatment in acute phase is immobilization, and in chronic phase, surgery might be recommended, which might include various procedures according to the discussion of the orthopedician and the surgeon. The next case, a 42-year-old male diabetic on OAD is present with difficulty in extending the middle finger and sensation of snapping in the base of the finger during movements. Yes, very common. It is trigger finger, and also known as tenosynovitis, wherein there is catching or locking sensation that may be associated with pain in the affected fingers, and there are palpable nodules present over there on the base, and mainly the orthopedicians treat it by giving corticosteroid in the flexor tendon sheath. The fourth case, a 45-year-old female diabetic for 7 years complaining of tingling sensation of tips of fingers on amitriptyline, pregabalin, duloxetine without any relief, and having weakness of hand grip, loss of sensation over the thumb, second and third fingers. I'm sure everybody will be diagnosing this as a case of carpal tunnel syndrome, and this is actually so. Carpal tunnel syndrome, this is the area of distribution of numbness and pain, and also we might have weakness and atrophy of the thenar muscles. And prevalence is 11 to 16%, not less, and the diagnosis is by positive Tinel's test or Fallon's test. And the clinical features are nocturnal exacerbation of symptoms or motor loss along with abnormal nerve conduction time. Treatment is by elevating local compression, underlying disease treatment including glycemic control, local corticosteroid injection, and orthosis, and also surgical division of the transverse carpal ligament. Along with this, the Dupuytren's contracture is also very common. The difference between the Dupuytren's contracture found in diabetics and the non-diabetics is that in diabetics, the ring and middle fingers are commonly involved, wherein in non-diabetics, the little finger is commonly involved. Also, they are milder as compared to the non-diabetics, and prevalence progressively increases with age. So depression contraction, the prevalence is 20 to 63%, and main treatment is optimizing glycemic control, physiotherapy, local steroid, and hand exercises. And if not relieved, surgery can be planned upon. Also, there might be limited joint mobility known as neuroarthropathy, wherein there is no sex or race prevalence, a painless, non-inflammatory limitation of hand, feet, and large joints. PIP, MCP, and wrist joints and elbows and ankles are the ones which are more commonly involved. Begins usually with the fifth finger, and cervical spinal involvement occurs in the late severe cases or in late stages. Risk factors include advanced age, duration, retinopathy, nephropathy in type 1, and if the patient is having macrovascular complications in type 2 diabetics. Also, cigarette smoking is considered a risk factor here. Clinical diagnosis is by Prayer sign and Houston's tabletop sign. As you can see here, these two are the classical signs wherein which can be helpful in diagnosis of this condition. And treatment is glycemic control, physiotherapy, corticosteroid injection, and mainly the excellent glycemic control should be ensured. Stiff hand syndrome probably is due to vascular insufficiency, occurs usually in middle-aged people with diabetics of more than 20 years duration, wherein we have hard palmar skin, soft dorsal skin, calcified vessels on radiographs, and marked disabilities occurs. All fingers are usually involved. Tingling clinically presents with tingling or burning sensation of hand, very difficult to manage, and might be physiotherapy might help in reserving the hand function, and somewhat some relief may be obtained by that, but it is very difficult to manage. Diabetic sclerodactyly, wherein the thickness and waxiness of the skin most marked on the dorsal of the fingers, associated with limited joint mobility. Skin changes resemble scleroderma, and their frequency of skin change correlates with the duration of diabetes. And here again, improved glycemic control is the mainstay of treatment. DISH, or diffuse idiopathic skeletal hyperostosis. It comes in a very close differential diagnosis of ankylosing spondylosis, but ankylosing spondylitis occurs at a much earlier age as compared to DISH, and wherein there is new bone formation, particularly in the thoracolumbar spine and also around the hips, knee, and wrists. There is mild low back pain, and range of motion is preserved as compared to the if we compare it with angstpon, the range of motion is preserved, and this is more common in type 2 diabetics. This is an X-ray of a dish wherein you can see that there is flowing ossification here, and there is a space between. If we see this blue arrow, this blue arrow is the anterior aspect of the vertebral body, so it is separated from the flowing ossification. There is the well-marked space which helps us to differentiate dish. Dish opla, or ossification of posterior longitudinal ligament. PLA may ossify, narrowing of the cervical spinal canal, and canal stenosis may occur. Cervical spine is more common, also seen in dish who consume high salt and meat products, wherein stiff neck is the most common manifestations. RSDS, we all know, it is also known as algodystrophy, wherein there is localized or diffuse pain associated with swelling and trophic changes. Condition may occur spontaneously or after minimal trauma following surgery or fracture. Predisposing factors include diabetes, hyperthyroidism, hyperparathyroidism. Treatment include analgesics, physiotherapy, or intravenous bisphosphonates. Outcome usually good. Diabetic muscle infarction usually affects the prolonged diabetics and who are poorly controlled, wherein there's acute onset of painful swelling of thigh, more common in type 1, and who are having multiple microvascular complications. MRI shows edema on the involved muscles, and where herein this is a condition wherein the CPK may be raised or may be normal. MRI T1, there's iso-intense swelling, and T2 is heterogeneous hyperintensity, self-limiting, rest, may need opiates or antiplatelets. Osteoarthritis, well, I don't need to discuss about this disease in detail in this August gathering, but obesity is a risk factor for osteoarthritis as well as diabetes. So it is still not clear if diabetes or obesity is a cause of this osteoarthritis. And treatment mainly weight reduction, as like any other patients, will ask for a weight reduction, resting the affected joints, medication for pain, and in rare cases, surgery might be needed. So osteoporosis, risk factors include poor glycemic control, nephropathy, neuropathy, or diabetic diarrhea, and the other diseases which might be associated with osteoporosis, include Graves, other autoimmune disorders like celiac disease, maybe amenorrhea, delayed puberty, or eating disorders. So now the last case, 55-year diabetic who is diabetic for 7 years on sitagliptin, metformin, losartan, and atorvastatin, having multiple joint pain for 2 months, which is non-migrating. On examination, having non-inflammatory joint pain, glycemic status is maintained, euthyroid inflammatory markers are normal, and the X-ray didn't show any joint erosion. This is my case actually. And so, what might be the diagnosis? If we see, this is a table from Hochberg, standard textbook of rheumatology, wherein we can see that there are many rheumatological manifestations of the antidiabetics. So, if we look at this case here, sitagliptin and the DPP-4 inhibitors are notorious to cause severe arthralgias. And so, this patient, I diagnosed it as a case of DPP-4 induced arthralgia, and we stopped DPP-4 and the joint pain disappeared. That itself proves that probably this was a case of DPP-4 induced arthralgia. So in the end, I'd like to summarize stating that musculoskeletal manifestations of diabetes mellitus are not uncommon in day-to-day practice. It actually depends on the duration of disease. Good glycemic control is the mainstay of therapy, but we should never forget drugs as a cause of musculoskeletal manifestations. Thank you all for your patience.